again, Kateřina, we're very privileged to have you here as our second speaker and our biological expert. I'd like to introduce you to our audience into a bit more detail. So Associate Professor Kateřina Machová Poláková is Associate Professor at the first medical faculty at the Charles University in Prague, and she is also head of the Department of Molecular Genetics and the Biobank at the Institute of Haematology and Blood Transfusion in Prague in the Czech Republic. Her research focuses on the molecular biology research and molecular monitoring of hematologic malignancies, with a particular expertise and interest in CML, including BCR-ABL1 transcript analysis and mechanisms of treatment response and resistance. She plays also a key role in international collaborative networks and reference laboratory activities in CML, contributing to the development, standardization, and quality assurance of molecular diagnostics used in clinical practice as well as in clinical trials. Great to have you here, and we're curious to hear your personal selection of biological abstracts from the ASH meeting.
First of all, thank you very much, Stephanie, for a kind introduction and invitation. Hello, everybody. Good morning, or good afternoon, or good evening. So I focused on two burning topics in current CML research. The first one I grouped into exploration of somatic mutations in CML. And the second topic I call TFR predictions from bulk to single cell analysis. So I will start with first with this short introduction. We all know that there is a growing evidence indicates that AXSL1 is seems to be the most frequently mutated gene at the time of diagnosis in chronic phase CML, and that AXSL1 mutations are observed across all age groups. And that there is also the emerging evidence suggests that AXSL1 mutations are associated with a poorer response to TKIs and significantly higher probability of acquiring BCR-ABL mutations. However, we still need to wait for more data, to do more research, to generate sufficient data to guide clinical management decision. There was a very important work presented by Professor Susan Brand from University Adelaide from Australia. She presented the first statistical analysis on 468 patients with chronic phase CML treated with frontline imatinib. She presented NGS data from CML patients across 12 centers in 6 countries, thanks to the iCMLf Genomics Alliance collaborations with the Harmony Alliance Foundation that enabled a secure integration and storage of clinical and genomic data from CML patients. Unexpectedly, this work showed that AXSL1 mutation was the most frequently mutated gene in this work, and other pathogenetic variants were detected in 20 genes. It is important to say that this study was retrospectively performed, so 20% of data was derived from patients who were selected for sequencing due to an optimal response. However, there was a significant observation in probability of failure-free survival. Looking at this graph showing probability to survive without failure in patients with no mutations compared to patients with mutations with pathogenic or with patients with pathogenic variants. You can see that patients with pathogenic variants had significantly lower probability to achieve failure-free survival. The same picture was shown if colleagues analyzed the patients with AXSL1 mutations. So Professor Brandford also continued with other important presentation from Ask for First study, because in this study enabled thanks to the stored samples, analyze ASXL1 and other cancer-related gene mutations from baseline through the asciminib and TKI therapy in both arms of the study. And they performed DNA-based NGS panel of 89 genes, and of course they focus on ASXL1 mutations. And also this clinical study proved that the most frequently mutated gene was ASXL1, again, 11% of patients, followed by the MT3A, MT2D. It is important to say that the vast majority of mutant ASXL1 clones present at diagnosis were eradicated during therapy in asciminib arm, and the TKIs treated patients as the second arm, and they achieved at least a major molecular response. However, looking at the longitudinal patterns of ASXL1 mutations, there were majority of patients in who ASXL mutations were eradicated through the therapy. So the patients, you can see, mostly achieved major molecular response. This was different to patients with persistent mutations since diagnosis. So you can see that the frequency of treatment failure were higher, and also the acquisition of BCR-able mutations. And there were also the group of patients who emerged ASXL1 mutations during therapy. Again, quite high frequency of treatment failure and BCR-able mutation acquisition, but you can see also that these patients, majority achieved major molecular response because ASXL1 mutation was present in a non-leukemic clone, which means reflects clonal hematopoiesis. And again, treatment-free survival was, the probability to achieve treatment-free survival was significantly higher for patients who were treated with asciminib and without mutated ASXL1 compared to other groups of patients. There was a very interesting work of a French group presented by Dr. Benjamin Podvin. There was a nice large group of patients with the rare BCR-able variant, minor variant. There were 42 patients available for the analysis. French colleagues created age-matched group of 42 BCR-able major positive CML patient to perform molecular profiling. And looking at the frequency of ASXL1 mutation, again, also in the group of patients who carried a BCR-able minor rearrangement, the ASXL1 mutation was the highest observed in this group, as also for the major. But the ASXL1 mutation appeared to be more frequently appeared in comparison to group with the major rearrangement in patients with minor rearrangement. Which is very, very interesting. And colleagues went into more details because they had stored samples from the follow-up. So they perform analysis during TKI therapy and showed based on the BCR-able transcript level and variant allelic frequency, they were able to divide patients into two groups. So there were 42 patients who in who BCR-able decreased to log decreased to 1% or MMR, and BCR-able was expected to be a primary event in 24 patients, meaning that the mutated clone was present within the BCR-able positive clone, and the secondary event that based on the transcription level of BCR-able and variant allele frequency, it seemed that BCR-able was the secondary event, and indeed they performed analysis from 3 patients from who they had stored bone marrow and performed single-cell proteogenomic analysis, showing that indeed BCR-able rearrangement was the secondary acquisition. It seems that these have some important clinical impact because secondary BCR-able minor group of patients seem to have some CMML-like profile with more cytopenias and transfusion dependence. So in summary, for this part, SXL1 was by this work proved the most common mutant gene in CML diagnosis, including in minor BCR-able cases, and there were other beautiful posters showing similar data. Its presence at baseline or emerging during therapy was associated with treatment failure. We saw more prevalence to disease progression, BCR-able mutation acquisition, and lower MMR rates. Secondary minor BCR-able events with ASXL1 mutation show a CML-like phenotype with deep cytopenias, while emerging ASXL1 mutations may reflect clonal hematopoiesis, and this warrant for the study. As the second topic, TFR prediction from bulk to single-cell analysis. Again, let me briefly introduce treatment-free remission is important goal for CML patients, but we know that only around 20% of all CML patients may achieve it. Still, the biological factors underlying the difference between patients who sustain TFR and those who relapse following TKI cessation are still poorly understood. So validated score to predict TFR is still missing in clinical setting. So we need to work on that, and they were very nice research on that. And I will start with the first one, which was from the Czech National Health Trial. We showed that the DNA-based MRD monitoring may enhance risk stratification during 2 phases of TKI dose reduction. This trial is led by my colleagues Jiří Majer and Daniela Žáčková, and we showed that stratification by MRD status, DNA and RNA MRD monitoring at 12 months may significantly predict molecular recurrence-free survival after TKI stopping, as you can see from this graph. The green curve shows a DNA positive, RNA positive group of patients with 87 probability, with the highest probability to survive without recurrence, molecular recurrence, following by intermediate probability group of patients with DNA positive, RNA negative MRD profile, and double positive profile patients. They have the lower probability to survive without molecular recurrence, even that the molecular relapse occurred only in this group of patients during the second dose of the escalation. And this graph shows here the dynamics of MRD changes during the TKI's dose de-escalation phases, and even more MRD changes after TKI stopping trials. So it seems that even in the green and yellow group of patients, some leukemia stem cells that were quiescent again were probably responsible for recurrence. And there were very nice work of French colleague from Lille, from France. They presented, or Dr. Vincent Alcazar presented work. They applied machine learning approach to identify transcriptomic signature that may predict treatment-free remission in chronic myeloid leukemia. So they had available samples from the STEAM2 multicenter trial before imatinib cessation. They randomly split the cohort into training and testing set, and then they applied the sophisticated bioinformatics statistical approach and machine learning on that. And thanks to them, they were able to identify 15 genes that were sustainably differentially expressed between groups with sustained TFR and group with recurrence. And you can see based on this analysis the significant difference in probability to survive without treatment. And also this was proved in the validation cohort. And looking in more details, the gene set enrichment analysis revealed that enrichment of glycolysis, angiogenesis, and tumor necrosis factor alpha signaling in the group associated with TFR, and while the enrichment of interferon alpha, gamma, and inflammatory response pathways were found in the group of patients associated with molecular relapse. Dr. Tyler Freeland from Ravi Bhatia laboratory, they showed their single cell based analysis of bone marrow samples obtained from CML patients who achieved deep molecular response prior to stopping treatment. They had available samples from 19 patients, and 7 patients maintained TFR, while 12 patients experienced recurrent disease. What was very important in this work that these variable rearrangements were indeed found in CML patients at diagnosis, the red dots in the majority of the cells. None of the BCR-able rearrangements were found in healthy donors. And what was important that even in CML patients who sustained TFR before TK cessation, and in a group of CML patients who recurred, the BCR-able positive cells within the hematopoietic stem cells were present. So what the key outcome from their work was that inflammatory signaling is increased in recurrent hematopoietic stem cells, which is very similar to the previous data from French group. So hematopoietic stem cell BCR-ABL positive, of course, from patients that recur after TKI withdrawal show evidence of altered tumor necrosis factor and TGF-B signaling compared to hematopoietic stem cells from patients that maintain TFR, indicating an association with the inflammatory signaling with recurrence. Again, very beautiful work also employing single cell analysis of bone marrow was from the was presented by Dr. Vaideshi Krishnan from Tiongong group from Singapore. They had available, and they raised a very important and critical question whether these analyses may predict treatment-free remission or recurrence already at the time of diagnosis in a patient. So they had available 30 bone marrow samples from 30 CML patients. Some patients who relapsed after TKI stopping therapy and who sustained in TFR. And first of all, what they create was a single cell TFR bone marrow atlas. So based on this, they showed that the relapse has compared to remission cohorts. There were no differences in composition of stem, progenitor, and immune cells. However, the cell state may drive relapse. This was the key question of them. So what they found that they were able, based on the data, divided or identified 2 groups of patients with molecular relapse. The group of patients, the relapse cohort was split into types based on the E2F transcription factor DNA replication enrichment patterns. So this group of patients with who relapse, they named this group relapse P, like proliferation primed. But the second group was quite different, and they raised the question whether this may be related to the immune pathway. So what they found for the second relapse group was that this group were associated with signaling of tumor necrosis factor alpha, which best explains the relapse in the immune group of patients. So in summary, a two-step TK de-escalation strategy with integrated DNA, RNA, MRD monitoring may reduce molecular relapse and improve selection for safe TKI discontinuation. However, we need more details. What is behind? What is molecular background of this observation? And the work based on single cell analysis or machine learning bulk analysis showed that hematopoietic stem cell signatures at TKI stop and leukemic stem cell signatures at diagnosis may predict relapse with recurrence associated with enriched inflammatory cell cycle and hormone signaling pathways. And relapse-related leukemic stem cells show two distinct states defined by MYC, the proliferation state, and tumor necrosis factor alpha signature related to inflammatory. This is all from me. The highlights. Thank you very much. Thank you. Thanks to all presenters who shared their presentation with me, and thank you very much for kind invitation and for listening.
Thank you so much, Kateřina, for this really comprehensive overview, and it was really rich, lots of new data, and I think lots of food for thought for our discussion. We're a little bit behind the schedule, but nevertheless, I think we should take time for a Q&A now. I've just checked the chat, and there are a couple of questions coming in, so please feel free to submit your either clinical related or biological related questions or translational questions into the chat for discussion. I've seen there are also a couple of, alongside clinicians and scientists, there are also a couple of patient advocates on the call, and we've got a first question from Giora Sharf, asking, I think that's a question for you, Ihab, for your overview of new compounds in development. What about the Enliven drug? Anything presented at ASH? What's going on here?
Good morning, Giora. Hope you're doing well. At ASH, as far as I could find, Giora, they only presented, in the large study, they presented 6 patients who had rare transcripts, which are resistant to other drugs, and Enliven did work. I didn't see anything other than that they presented, so I hope I didn't miss it. It's an active drug, but that's all I could find were those patients with rare transcripts. So,
thank you.
Thank you.
Wonderful. There is a second question here. Is remission really remission? I think we can put a more clinical or more scientific or biological perspective in answering this question. So whoever wants to go first, Kateřina, maybe you can start.
Yeah, the remission is not, it's a, let's say, if we detect 0 copy of BCR-ABL transcript or 0 copy of DNA genomic rearrangement, if we have the patient-specific assays, we still do not have to say remission in terms of that we are pretty sure that there is no cell in bone marrow carrying BCR-ABL rearrangement. So this is from my side.
Yeah, I think, I mean, I guess like there's another question in the chat, which is there any movement for a cure? So I guess that's the kind of connected questions. I think remission is remission when you, I mean, think of any other solid tumor. A remission means you can't see it, or it's not active, right? Sorry, go ahead, Kateřina.
Technically, it is remission. Yeah, that's why we're saying that measurable residual disease. So technically, it is remission, but biologically,
Correct.
You're
Correct.
not
I mean, it's
sure.
still there. I mean, I think
Still
that's where
there.
like the difference is cured or not cured.
Yeah.
And we could, I mean, patients who achieve TFR with all the neat work that Kateřina did with like the DNA and all that. Well, if they're not on drug and they're in remission, I would call that cure. But again, that is a small percentage of patients overall, and that's why I believe there's a lot of work to be done, because all in all, patients who achieve that TFR is 10 to 20%. So we are still striving for the cure, and maybe with the newer TKIs, maybe with combinations, we would get there.
Yeah.
Okay, fantastic. It looks like this is potentially a very big or bigger topic, and will qualify for another iCMLf conversation in the future. I think there is another question I think it's probably to both of you as well. In those patients with abnormal sorry, it's gone.
Hematopoietic stem cell or
Thank you for
leukemia
this.
stem
Leukemic
cell
stem cell
predicting relapse.
Thank you. How fast do they relapse if they choose a treatment-free remission approach?
Sorry, what was the question? Sorry, I didn't hear it properly. Whether
in those patients with abnormal stem cells or leukemic stem cells predicting relapse, how fast do they relapse if they choose a treatment-free remission approach? I think that's the question.
This is a very good question, and it needs to be answered. But from the clinical trials, we know that the majority of patients with straight TKI stopping, the most relapses occur within the first 6 months after TKI cessation. But we have also patients with the relapse that occur later. So, and of course, I think that it needs to be, we need to look also the B-cerebral kinetics, and we know that within the first 6 months, the kinetics of B-cerebral is really, sharp, that it's really, really quick. And in late relapses, it's different. So they probably, there are differences between the leukemic stem cell that preserved. What do you think, Ihab?
Any comments?
No, not really. I mean, I had nothing to add, Kateřina, really.
Okay, fantastic. I have another question. There are lots of questions coming in now. Very busy. So another question for Ihab. In the Escalate second line studies, were there any cases with mutations?
Yes, good morning, Beppe. Yes, there were, but it was very few, like 3 patients in total. So very, very few patients had. And of course, patients who in the S to escalate T315I and any asciminib known mutation were excluded. So 3 patients had a mutation, so very few now out of the 100.
Okay, thank you so much. Lots of questions coming in toward the end. So I pick up another one. It's more related to Kateřina's presentation, but feel free, Ihab, to jump in. In CML, does a vicious cycle exist whereby high BCR-ABL1 derived ASXL1 mutant clone dominance, which in turn impairs differentiation and further elevates BCR-ABL? If so, could targeting ASXL1 break the cycle and restore molecular response? A question from someone from Ethiopia.
Yes. So the question was whether ASXL1 mutated protein can be targeted in case that the ASXL1 mutation is within the BCR-ABL clone. Am I right? Did I?
Yeah, I think it's got like both directions, a vicious circle, like high BCR-ABL drives the mutation and the other way around.
Okay. So it's a good question. It may be helpful to target ASXL1. I don't know whether some drug is available. Ihab, do you have any idea? I'm
There's
not
none.
sure. So maybe we need to target other pathway, or I still think that ASXL1 mutations alone detected at diagnosis is as alone factor is not indicative for combination therapy, because as the clinical trial, as I showed us, ask for first that many patients or majority patients with ASXL1 mutation achieve MMR or deep molecular response. So we need to still monitoring BCL transcript level, of course, and in case that the declination is not occurred during TKI therapy, including asciminib, then the combination therapy may be important or appropriate. We know that good results are from combination therapy, TKI and venetoclax, for example, in other clinical trials, but this needs to be investigated. So it's difficult to say now, but
Yeah, I agree. I mean, completely agree. We wouldn't start that with combination data. I mean, still patients respond. It's kind of a marker of like, be aware, be careful, monitor your patients closely. Samuel, as I've looked into ASXL1 inhibitors, to my knowledge, there's nothing specific in the clinic that works. There are some suggestions of things that might work, but if we discovered that, we would be kings of the world. It would not just in CML. So.
Okay, fantastic. Looking at the time, I think I pick one last question from the chat. I think a bit more clinical related, but to both of you. Does early detection of CML influence treatment-free remission success? Very big question.
I'll take that. Okay, so I don't know. We don't have the answer to that. You could possibly extrapolate based on the so-called risk, that if someone who presents with a low risk so-called has a higher chance of achieving TFR. However, that's not definitive, because maybe patients who present with a high risk so-called have a much more proliferative disease. So we don't really know. If I monitor a CBC on everyone every day and I can pick it up and when it's low risk so-called, will that lead to benefit? That's one view. The other view is, but maybe the patients with high risk so-called have a very, very high proliferative disease. So to start with, they have a different biology. Long answer to your question, which is we don't know.
Anything to add, Kateřina, here? Or
I agree with that. We definitely need to wait for more data. It's difficult to precisely answer this question, of course. Yeah.
Okay, wonderful. This brings me, looking at the time, we're coming to a close. This brings me to my final question to both of you, with more like a view of the translational aspect and the opportunities. So where do you both see the biggest gaps and/or biggest opportunities between biological insights and clinical implementation in CML? And what do you hope to see at the next conference next year?
Who's going to start? I start. Okay. I think I'm slightly sold on combination therapy, maybe not necessarily BCR-ABL. So I think that would be the next step, but not for all patients, for a certain group of patients. And as we all know, doing research is difficult, because patients are doing well. The acceptance of any side effects to achieve TFR, get to a deeper remission. A lot of my patients at least hesitate to do that when they're doing well with their TKI, of adding more toxicity with a question. So I think that is our challenge.
May I make a comment, if you can hear me?
Yes.
Yeah, please.
This is Dr. Naim from King Faisal in Saudi Arabia. My questions to the speakers as well. I can see Beppe on the screen also. That should we not move beyond the so-called or the ELTS score to incorporate these, so much of data coming out on these genetic factors and additional genomic abnormalities, to build a new risk profiling? So one can select, because the cost between the different TKIs is enormous. For example, imatinib is $40 for a month compared to $5,000 for asciminib, for example. So maybe we need to build up gradually on all this data and all this information to create a new profile for the risk factors rather than just a so-called or the ELTS score to proceed with the TKI combination or whatever. Maybe it should be selected. Just a comment. Thank you.
Well,
do you want to comment, Kateřina?
Yeah, we agree. The so-called is when you think of it, it's the square root of something very complicated. It's very difficult to measure the spleen size. So I do think we need a better scoring system. Having said that, in the molecular, it's only 8 to 10% of patients who have baseline mutation. So we need a new one, at least one that doesn't have the spleen size, so we can actually calculate it. So we'll be working on that.
Okay, fantastic. I think we have to come to a close now. It has been a fantastic presentation and I think a very interesting and vivid discussion. There are a couple of more questions coming in, so I encourage you, if you have or there are more questions coming up, please feel free to email us at info@cml.org and we can share your questions with the experts. Before I come to a final thank you, I'd like to share my slides again for a couple of resources I'd like to share with you. Here we are. Here are a couple of interesting resources for you in case you haven't seen it on our website. The recording of this webinar will be made available on the iCMLf website within a couple of days or next week. If you haven't seen it, we have also shared summaries of written summaries of key sessions from ASH. So if you want to sort of have a recap, please feel free to visit our website. And here are a couple of additional resources like the Knowledge Center, the Case Discussion Forum. So it's probably worth with it. And if you want to use the QR code, you will be directed to our website. Last but not least, this is time for a big thank you to both of you experts, Ehab and Kateřina. It was really rich, really comprehensive, wonderful that you made the effort and the time to share your perspective and your expertise with us. Thank you to all of you for joining us and for submitting your questions and for sort of facilitating the discussion. And we hope to see you at our next iCMLf conversation.